Thank you very much. Without delaying, we are already delayed. So I will go quickly. Good evening, ladies and gentlemen. Within next 10 to 15 minutes, I will present real world experience, what we do in the front line and how we choose in the relapse and refractory cases. And again, the big question is what we face challenges in the mantle cell lymphoma in 2024. So why we talk mantle cell lymphoma, everybody know, because it's incurable disease and shorter natural history. It has remained challenge. Although mantle cell lymphoma is disease of just 3 decades, but it is moved from good treatment options, which we have discussed. So how we choose in hematology, which guideline will you choose by algorithm, as everybody presented, we choose by NCCN guideline. And for cutting edge, we use local guideline, PubMed, and UpToDate, and sometimes we do expert online in real world experience. So how I do mantle cell lymphoma, I go by A to G. A means accurate diagnosis, then B, before beginning treatment, check indication, then consider a good drug with a feasible and less side effects. Here I will go accordingly. The first case is the young fit patient, and yes, this is 55-year-old male who has about 10 years ago, who had history of weight loss, significant weight loss, about 30 pounds, but denies a fever, anything in cut shot. He has abdominal lymphadenopathy, which was about bulky disease and retroperitoneal lymph node. We did biopsy, and biopsy confirmed it is CD5, CD20, CD23 positive, and cyclin D positive, which is confirmed mantle cell lymphoma. Here you can see the CT scan, how it was worsening the disease. And for prognostic and staging point of view, as everybody mentioned, it is Ki-67 proliferation, which was 70% in this patient, and all the factors of score of BP score, A, B, C, D, age, beta-2 microglobulin, LDH, and CBC all were high, so it is very high risk mantle cell lymphoma in young patient. So again, before beginning, check the indication. Yes, patient has indication. He has a classical wild P3 mantle cell lymphoma, aggressive with high MIPI score. So what treatment should be given? Again, as per NCCN guideline 2024, if you see now, even I use it 10 years, but you can see the treatment is, aggressive therapy and followed by autologous transplant. But now currently, as Dr. Ruba has also mentioned that, we can aid on BTKI as well. So in this patient, this is 2024, already mentioned, we have now Lyme trial, we have Triangle, we have Hyper-CVAD, and in patient who cannot take in treatment, they can go to BR or BTKI inhibitors. So what we did, again, in Expert Online 10 years ago, I put all this patient data, and they recommended actually patients should go for or Hyper-CVAD or alternating Hyper-CVAD and RMA protocol. So based on if any young patient, we have this abstract in those days, 2016, here you can see R-CHOP plus RDOP therapy, which has shown up to the 6 years data, very high outcome as compared to the R-CHOP therapy. And Nordic trial has shown that high dose RRC with Hyper-CVAD has shown the excellent outcome. And also the Lima trial has shown the maintenance of rituximab has changed the outcome of the mantle cell lymphoma. Now coming to my patient, the patient was in those days is 55-year-old active mantle cell lymphoma. He was treated with R-CHOP and RDF, followed by autologous transplant, and we gave rituximab 2 years of the maintenance. So he enjoyed 7 years, and after 7 years, when he became 62 years old, he developed again abdomen pain and worsening lymphadenopathy. Again, CT scans revealed 7-centimeter lymph nodes, and confirmed the mantle cell lymphoma. Now, what we should do, it was 2022 when he relapsed. In those days, you see second line, you have BTKI, or you can give bendamustine rituximab based therapy, and then patient can, if he's eligible for transplant, he can go for transplant. So in this patient, we gave actually BR based chemotherapy and followed by maintenance of rituximab 2 years, and he enjoyed 4 years of the PFS in those period. Then again, he has second relapse. So now this is second relapse. So again, putting in this is Expert Online, and they recommend in those days in ibrutinib actually, and then based on what based on you already seen this trial, they have shown PFS with the ibrutinib is 13 months and overall survival is 2 years. So we started actually ibrutinib, which was 560 milligram per day. He responds, but after 3 months, the patient developed respiratory symptom and severe pneumonitis. And now if develops severe pneumonitis, we decrease the dose, but patient couldn't tolerate the dose. So what is the next option in this patient? Again, if you go by, again, NCCN, we have other BTK inhibitor, which are less off-target side effects. And it is shown that ibrutinib has shown the pneumonitis as serious rare side effect can be happen with the ibrutinib. So now, based on the phase 2 ASILE trial, they have shown if you give acalabrutinib, it not only increase the PFS here, the median PFS is 22 months as compared to ibrutinib, and overall survival is also 60 months, which is the update of the 3 years of the data. So in this patient, what we did, we started acalabrutinib 100 milligram twice a day, and patient is taking now 100 milligram twice a day since 1.5 years, and he's doing great. But again, the question is when the patient will be again after 2 or 3 years, suppose 70 years, I just put, if progress disease, what is the next option we have available? Again, I put expert online. If relapse, what are other options? Now, many things are coming. You can give venetoclax, we can give pirtobrutinib, or you can give CAR T cell therapy. Pirtobrutinib based on the BREN trial, again, 300 patients, they have shown 50% response, the patient who are taking BTKI. And similarly, CAR T cell therapy has shown, you can see about 90% they have shown even with heavily treated of the patient. So this is the small journey of my young patient. Then one old patient who is also fit but old by age, 78-year male gentleman. He has small lymph node, and that was actually not any B symptom, anything. FNA was done, then finally biopsy was done that confirmed it is mantle cell lymphoma, but Ki-67 was less than 30%, no other symptom, LDH and CBC, all the things were normal. So he is actually, by definition, is low risk. And if you go by NCCN guideline, in those days, I put in 2019 when I saw the patient who's asymptomatic, no other indication of treatment, the recommendation is observation. So we kept this patient under observation. Now here you can see after 3 years, patient developed B symptom, and he also developed high WBC count and high LDH count. And this time biopsy revealed 46% of Ki-67. In this, he fall in intermediate risk category. Now this patient has indication of the treatment. So again, I put expert online. So all they recommend, actually here you can see BR-based chemotherapy was offered actually in this patient. And if you put now in, I just for interest purpose, I put an expert online in 2024, and everybody recommend, you can say 60% they are recommending BTK inhibitor. So all the three they are recommending is better. This patient should go BTK inhibitor. Choice is you would choose first generation or second generation. Now, BR-based, everybody know this is the BRIGHT trial. They have shown in mantle cell lymphoma very good response. So somehow in this patient, actually, we started BR-based therapy 6 cycles and followed by rituximab after 2 years. And now again, after 1 year of completing the rituximab, patient developed again lymphoma, came back with the Ki-67, again 46%. Then what are the options? Again, as I mentioned, if you go 2024 NCCN, expert online, because NCCN guideline have given you free hand which drug or which treatment you can choose. For interest purpose, I put expert online, CCO expert online, and they also recommended this patient should go covalent BTKI inhibitors, which is choice as yours. But again, the three expert, they have clearly mentioned second generation Acala and Zeno is better than the first generation, their choice. So in short, I presented 2 cases. First is the young patient who have gone through the high-dose chemotherapy, autologous transplant, and then rituximab, and then disease came back. I gave BR-based chemotherapy, and then finally, third line is BTKI, and fourth line, you can say, Acala was given to the patient who couldn't tolerate the first generation. And similarly, in second patient, which was old patient, you have seen we have given BR, rituximab, and then followed by the Acala-based therapy. So this is my final closing question. You have now option, first generation, second generation BTKI, and some other experimental therapy. Thank you very much. To save the time, I went fast. Sorry.
Thank you so much. I mean, excellent presentation and two different cases, and you covered almost all the data and the and on time. So I would ask all the speakers to maybe open the camera so we can just start maybe the discussion. And while waiting maybe for questions from the audiences, I mean, we've seen excellent presentations by all the speakers, and I think that's the beauty of having different practice. And it was clearly in the relapsed setting, there's no, I mean, all the data about the BTK and novel agents, but however, there is no, I would say, guidelines on the sequencing or which would be the best. Let me start with Dr. Riyad, presented on the bispecific and follicular lymphoma and CAR T-cell. So you have the two options available at your institution. Where would you put that in the management plan of relapsed refractory setting? How would you alternate between the bispecific and CAR T-cell for certain patients who progress, let us say, on the either BR or R-CHOP follicular lymphoma? Dr. Riyad? Right. Okay, I think while we are waiting for Dr. maybe Riyad to join, we'll go to the mantle cell lymphoma. And I think we at least for now, we know from all the studies that we have now, two things. If you put the novel agents with the front line, either with the triangle, we've seen it also with the rectangle also study. We've seen it also with the SHINE study. We have clearly the progression-free survival benefit. However, still the overall survival not yet mature to be presented. And the question, I'm talking here about the TP53 wild type, not mutated. And Dr. Aruba showed us the NCC guidelines having the triangle as one of the option. Given there is no yet overall survival benefit, would you, for majority of the patient with the TP53 and no other high risk, just the classical type, no polymorphic, no plastoid, the KI less than 30%, TP53 expression is less than 10%. I mean, just talking about the usual presentation. Would you consider that option as in one of the management? I will start maybe with Dr. Salam.
Yeah, no, honestly, we don't. And for two reasons. One, we have the long-term outcome with the transplant. I mean, giving the R-CHOP rehab, and then salvage, with the consolidate with the transplant and then maintenance. We talk about 10, 12 years of follow-up. We talk about 6 years of those patients, at least over 50% of those patients to be alive in CR above. And always the discussion when we discuss these cases in our MDT said, we want something to, to lean on when the patient progresses. If you use all your guns for a standard risk is really too much. So I always say, don't be the first to change, don't be the last. I think we need more data, more follow-up, and more data, whether it is triangle being duplicated or rectangular when it is rectangular, or when it is really in complete form where they have the two arms with and without transplant. That will give us, I think, a long follow-up, and then we have data from two. And at least in our center, we don't have pirtobrutinib yet. We don't have CAR-T. So those patients, I mean, might be in a dilemma where when they relapse and you have these options not available for you.
Okay, Dr. Ruba, any comments?
Yes, in fact, in fact, ibrutinib addition in the TRIANGLE trial benefited most patients, all patients, including patients with TP53 or wild type or the mutated type. So if we can see, in fact, the curve of all the subpopulation, in fact, there was no time to show all the results. All patients benefited from the addition of ibrutinib in terms of PFS. The only question that was not yet answered, whether transplant is required or whether ibrutinib can override the benefit of a transplant, and this was considered not enough events to really answer this question. So the trial, at least from PFS point of view, has given enough evidence to add a BTK inhibitor to improve at least PFS. So there is improvement of PFS. So in our center, not yet that we have included any patient with the addition of ibrutinib, but we are already discussing this. It's not easy to change your habit, and I can understand that overall survival benefits are not very clear. And shall we remove transplant, yes or no? This question is not yet secured. That's why the TRIANGLE trial result is not mature enough, because will you give transplant or will you remove transplant if you add ibrutinib? Because I cannot answer this question yet, and they can't. Maybe I'll wait also, as Dr. Sam said.
Good. Dr. Lal, any further comments on this question?
Yeah, I agree with everybody. This is open, actually. You know, in 2024, mantle cell lymphoma is still incurable disease. Everybody agree, no? It's not curable disease. So best is there, you know. TRIANGLE is the best is there so far. We always choose, Dr. Rufa knows, always in all the platform, you know, we choose NCCN guideline. Anything is NCCN guideline, we are free to use it. So now in 2024, any patient, mantle cell lymphoma, come to us, young patient, we will go as for a TRIANGLE-based trial. We will add, you know, R-CHOP slash RDAP plus minus, you know, Acala, ibrutinib, whatever. And then patient, you will see, you know, what upcoming data is coming. Because, you know, they have mentioned category 2A. It means such a good evidence we have. If, you know, we have access, why not we choose it? As we know, this is the incurable disease. It will eventually relapse. You know, we have seen in myeloma, we are using everything, no? Like DARA, KRD, all these things. So why not we should give a chance to mantle cell lymphoma to add on something to get a better and better PFS. Thank you.
Perfect, thank you.
We don't have enough long-term follow-up, and I understand maybe you don't have high-dose chemotherapy transplant in all of your centers yet. So, I mean, if the patient progresses after this, what do you do? I mean, you have no other options. You don't have bertebrutinib, you don't have CAR-T. So, I mean, I think, you know, I understand it is appealing, but, you know, these things have to be kept in mind. Guidelines are just the suggestions, are not... No.
Listen. We have a lot of option. And mantle cell lymphoma, which you're treating 2024, it will come 2035, maybe 2030, like this. Many things are upcoming. CAR-TCL is there, 100% response with a heavily treated patient you have seen. So many things are coming. And non-BTKI, you know, BTKI is also, you know, upcoming. Not only one, this ibrutinib. There are tons of the non-BTKIs coming. So many things are coming. After 3 to 4 years, you will see more data and more things are there. So better, you know, we have to choose. As you know, mantle cell lymphoma is just disease of 2 decades. It's not very old disease. It is, if you see, it is 1995, one patient, first patient mantle cell lymphoma was labeled. So within 25 years, you know, they are developing era. Still, we are not reached from incurable to curable. This is the ongoing things. So I think we will use it. Thank you.
Let me just move to another question. I'm not sure if Dr. Riyad joined or not yet. No, I don't see him.
I'm already in, but apparently you were not able to move to hear me.
معلش, sorry, Dr. Riyad. So
I heard the question and I was answering actually. That's okay.
Let me flip the question, Dr. Riyad. So we've talked about the TP53 wild type and the role of the BTK in the front line, and if we heard the opinion from the speakers. If we have a TP53 mutated, and that was by the, let us say, confirmed by the NGS, and we know from the data from the Nordic study about the outcome of such patients. Their survival is less than maybe 2 years with even the chemoimmunotherapy. So would you consider a novel agent with chemoimmunotherapy and transplant, or would you consider a novel agent single or combined with another novel agent without chemoimmunotherapy? So my question about chemoimmunotherapy as a backbone and stem cell transplant plus the novel agent for the TP53 mutated patients.
Yeah, so for these are the tough group of people, TP53, and as we've seen in CLL, the median progression-free survival of these patients once they receive chemotherapy, any sort of chemotherapy, is around 6 to 12 months. So we're shying away from chemotherapy in these patients and using smart agents combination. So we have now BTK with venetoclax combination plus anti-CD20. We do have the CAR T cell. Of course, we still have allogeneic transplant as well. So we're shying away from auto-transplant, high-dose chemotherapy, and chemotherapy in general in these patients.
Okay.
If you have the available options, my selection would be a combination of new agents, so BTK plus venetoclax plus rituximab, and then in the second line, if your patient progress, then the non-covalent BTK can be used and eventually move to CAR T cell in older patients, and then possibly allogeneic transplant in patients who are fit and young and have matched sibling donor. But I would shy away from chemoimmune.
Sure. Dr. Ruba, to the case you've presented, and thank you for sharing that case because it's honestly a learning case for all of us. What things would you done differently if you have all the options, and what things would you haven't done in that patient based on if you have all the resources and the data we have nowadays? What would you done differently, and what would you say, I should have done this, not that?
This is a good question because, in fact, this is exactly why I discussed this patient and even reviewed the case, because we are trying now to do the TP53 for all the patients upfront. For example, my patient, I don't know his TP53 on presentation. In fact, it was not available as immunochemistry, histochemistry, and the sequencing in general also is not done in-house in our center. So probably also with the triangle trial showing benefits of the ibrutinib, especially in the patient with TP53, I think that these are important information that we need to acquire in every patient in order. If I see TP53 upfront, I would give the triangle regimen definitely. I wouldn't be like hesitant, shall I do transplant, not transplant? The most important for him is to receive the novel agent. Maybe if I get another patient after allogenic transplant, that I put the patient on ibrutinib maintenance. It is not studied. The patient, in fact, didn't have a lot of complications, but also, giving BTK inhibitors, it's cardiotoxic. It's not an easy decision without evidence. But who knows if he received a BTK inhibitor, knowing that he's TP53, maybe it could have improved his PFS. I can't answer this question.
Okay.
Yeah.
And I think the last question from my side, then let me just take one of the questions, I think, by the audience, and this is a general question asking what's the early warning signs of lymphoma, and if a pregnant can lymphoma cause a miscarriage while on treatment? I think this is a general question, Dr. Lal. So, and maybe we'll just talk about just briefly because maybe our audiences would like to know more about the lymphoma presentation and specifically mantle cell and management of maybe a lymphoma or diagnosed lymphoma during the pregnancy.
Yeah, actually, lymphoma is, it can be asymptomatic to symptomatic generally. Mostly it's symptomatic. As I mentioned, in mantle cell lymphoma, there are two, spectrum from spectrum 0 to spectrum 100. So if patient is asymptomatic and the patient has low biology, then, we don't treat it like this way. And if the patient is symptomatic, then we treat it. Again, coming back to the pregnancy, the patient, we have so many times, pregnant ladies, they present with the lymphoma. Again, depends on the which trimester, first trimester, second trimester, third trimester. First trimester is really challenging. We have to discuss regarding, because all chemotherapy, the lymphoma is curable disease. It's a big debate whether terminate pregnancy, not, because all the lymphomas are almost, aggressive lymphoma, they are curable. Even these mantle cell lymphoma, PFS 7 years, 10 years, almost reaching to the curable stage, you can say we are moving. So depending on the scenario, depending on the term of the pregnancy, we have discussed, we have done also sometimes, first term, termination of the pregnancy, we start treatment. If young patient, how much family they have, like some patients, they have second and third term of the pregnancy, then we can go ahead for some therapy which are safe, like even breast cancer, suppose they use all these cyclophosphamide, adriamycin. Similarly, CHOP-based chemotherapy can be given, and rituximab you can keep for future as a maintenance. We do accordingly extrapolate and treat the patient. Thank you.
Thank you, Lal. Question maybe to all the speakers. I mean, we've seen the let us say when the BTK was combined with the R-CHOP into the triangle study, compared to the ibrutinib to the BR into the SHINE study. A more toxicity reported in the SHINE, and I think if I remember correctly, there was a more death into the bendamustine arm plus the ibrutinib, about 11% compared to the other arm. Choosing the backbone that would combine with the BTK inhibitor, how important is that? I mean, we're still waiting for the ECHO trial, which will answer that question for sure. But based into the SHINE results, the ibrutinib was withdrawn from the US market, and they are not using it anymore based on that. So any expectations? Seen Dr. Salim presented the R-CHOP plus the ACALA, I think, or maybe Dr. Ruba, the single R. Do you think the backbone will affect the outcome, either primary or secondary, when combined with the BTK inhibitors?
Yeah, I mean, I actually presented ACALA R-CHOP, but this was phase 2 and single arm. I think it is important, given, the SHINE and the triangle are different patient population. So the R-SHINE was older patients, so you would expect more comorbidities and those patients and higher frailty. So I'm not sure we can just blame it on the backbone, but I think that is very important. And this is why, all these should be in phase 3 trial. We have to have a long-term follow-up on those patients. And we see sometimes, toxicity, not only because of the we've seen this in the follicular lymphoma, when they use the blinatumomab, which is a more potent than anti-CD20, there are higher rate of infection, higher mortalities even in those patients. So the combination and the type of patient and the type of population we use, this combination is very essential to study very well.
Okay. Excellent. Any further comments from our speakers or anything? I think we are almost like 6 minutes late in our time. Thank you for the excellent presentations, for the answering all the questions, and thank you for the audiences staying until this time with us. Thank you again for AstraZeneca for supporting this event, and inshallah, hopefully we'll see you in another hematology forum discussing another topic.